button, Paloma, it might just prompt you so you can go ahead and minimize that or press OK if something popped up. But if not, I'll go ahead and hand it over to you.
Okay. Hi, I'm Paloma Sanchez, LCSW. I have been a clinical social worker for over 25 years. I went to UC Davis for undergrad and Rutgers University for my master's. Had private practice for over 20 years. And I have been working with suicide and diagnosing and doing psychotherapy for over 25 years. Just a little past history. For the first 7 years, I worked with County Mental Health. And there I worked with actually doing crisis counseling, training police and sheriff departments in crisis intervention and 5150s. I worked with youth, adults, and elderly. And I'd go to ER and the jails and actually go out with the police departments to hospitalize people, which has now come back in vogue. But we did that a long time ago. So we'll talk a little bit about that. Then I was with the California Department of Corrections for over 17 years. And there I was the supervisor trainer for all the correctional counselors regarding suicide prevention and developmentally disabled, and was also the coordinator for the outpatient hospital unit, which is actually like a ER, but in a prison. And also trained in Milo and crisis intervention and use of force. So what I'd like to talk to you about is we have actually is Pathwarm, and we'll talk about that. We're going to go through some statistics really quickly and then go off of what we use at the prison system. Oops. Okay. And so we're going to go through that as well. So first of all, we're going to look at depression. 37% of women have been diagnosed with depression compared to 20% of men. Women are more likely to seek mental health treatment, and thus that could be part of the problem of more men actually committing suicide because they don't reach out for help as much as women do. More men die by suicide than women, at 4 times the rate. Men are more violent when they try to kill themselves, so they will use, guns. Typically, women use more gentle methods such as pills and actual sanguination, which is bleeding out, which is oftentimes not a complete suicide, thus they survive. So that's part of the reason they don't die as much as men do. And we have age. So men older than 75, more of them we're finding are self-induced death due to, oftentimes chronic pain and feeling alienated and isolated because oftentimes they're widowers. So there's more of that. The suicide rate for boys and young men, 15 to 24, rose nearly half between 2001 and 2021. And people older than, and this is blocked off from me, typically for like white males, it's over the age of 45, but have a higher rate of suicide than under 45 years old. So this is the ethnicity of people that have the highest rates: non-Hispanic American Indian, Alaskan, and non-Hispanic white. In corrections, actually, the Hispanics have more of a suicide higher rate than anybody there. And there's 2 different factors with that, actually 3. The first factor is traditionally Hispanic people have more of a larger family and more support system on the outside. So when they come into prison, they're more isolated and alienated from their families. The second is a lot of the younger men that come in are on perhaps Prozac or another antidepressant. And because of their gang affiliation, which they have to pick when they come to prison, they have to go off of the medication. That's one of the gang requirements. So oftentimes they'll become more depressed because they're off the medication and will then try to kill themselves. And the third is also part of the gang is Hispanic males. If, let's say, they rat out somebody in their gang, they will actually be threatened to kill themselves. Otherwise, their family will be killed. So we found a lot of more people killing themselves because they're saving their family versus actually being suicidal. So again, the most common method is firearm, and second is suffocation. Third is drugs and poisoning. In incarceration settings, that is hanging, since they do not have access, obviously, to guns. So that's different in incarcerated males. And in women, typically, their suicidal ways are in prison are sanguination, which is bleeding out and cutting on themselves. So this is Pathworm. And we actually use this, we started using it when there was a 45 to 100,000% of people killing themselves in prisons. It was the highest rate because the national average was about 30 to 32. And so we did a massive training. I was the supervisor coordinator at the prison. Each prison had one person that would go and train and then train everybody else at the facility. And so this is good for, and a lot for people that are like teachers, physicians, nurses, anybody that's like working with somebody that they're noticing. And these are kind of a quick is Pathworm, and we'll get more into each one individually, and more clinically as well, because clinically it's different, because oftentimes people say, well, I referred this person and why weren't they fit all of this criteria in my mind, they think. And so I'm going to explain to you clinically why maybe the person that you referred did not fit that criteria. Also, clinicians that don't do 5150s, they can also use this as a referral. The other thing is with 5150s is it's not the answer to a lot of things. And a lot of people don't understand the process of 5150s. And also that sometimes therapy and other treatment plans would be better than putting somebody in to be 5150. So we'll kind of go over that as well. So I'm going to go over, I'm going to just read a little blurb here. And it was a case that happened in 2014. And so you're going to remember this, and then at the end, kind of check mark the boxes of what this person did and what you would have done. So this was in 2014. It was at UCSB in Isla Vista. And there was a gentleman who was 18 years old, and he killed himself. He killed 6 people and injured 13, and he was a student there. The first thing he did was he drove to Alpha Phi sorority and killed 3 people there. And then he drove around and went to a deli and shot other people and shot himself in the head. He actually wrote a manifesto that he sent out on Facebook 3 weeks prior to his killing spree. It was called My Twisted World. And he sent it to his friends, his therapist, and his family. He had anger and frustration towards his girlfriend, a hatred of women. He was against interracial relationships and minorities. He'd been bullied since he was young, and especially in high school. And he had recently been dropped by his Malaysian girlfriend. And he'd been in psychotherapy since he was 8 years old, but stopped at 18. His parents contacted the police, and the police went over. And they knocked on the door, and prior he bought 3 weapons as well. And the parents told the police that as well. So the police knock on the door, they go, hey, what's going on? And he told them it was, quote, a misunderstanding. And they did not search his apartment. They did not go into his apartment, which we'll touch on later. And if they had, which is again why it's important to have mental health or the training to have gone in, and then they would have actually hospitalized him for danger to self and others. But instead he went and killed all of these people in college. So what we're going to look at is the ideation, talking of wanting to die or looking for ways to die. So we have active and passive ideation. An active ideation is I want to go tomorrow and go jump off this bridge, typically San Francisco Bridge. It's the top place to kill yourself in America. That's an actual plan. There is a passive ideation, which perhaps, like, let's say you're driving around and you're like depressed and you go, I wonder what it'd be like to go off the cliff. That's more of a passive ideation. And so oftentimes we'll see people that are referred that said, I wanted to go run in the traffic, which is oftentimes what homeless people do in more of the ER setting. And what we look at is, did you actually go to the highway that you were on? Or is it just a fleeting ideation? So it's actually looking clinically more why that person, did they actually go? Did they think about it? Did they step over that line to go into the traffic? So that's more clinical questions we ask. 12 million adults seriously thought about suicide, 3.5 million adults made a plan, and 1.7 adults attempted suicide. The thing with suicide is, if you can actually stop it the first time, if you have your first intervention, you've reduced the reattempt of a suicide by 90%. So only 10% go on to actually try to kill themselves a second time. So what we look at is also how many times have you actually tried and what was the severity of it. And so people that have tried to kill themselves 2 times or more have a 50% more chance of actually killing themselves. So it's really important for that first intervention and getting into therapy, which will then prevent 90% that you're not going to kill yourself again. So then we have the substance question. So the substance is typically what we see when people come in and they say, I want to die, I feel like I'm going to kill myself, I'm paranoid, I'm seeing things. Oftentimes that's drug induced. And for example, one person was about 18 years old, was going to college, and he came home and visited mom and dad, went to Oakland, bought some K2 spice, which is synthetic marijuana. And he had a psychotic break. His parents freaked out. They thought he was actually having a schizophrenic break because he said, I just smoked some pot. So they sent him actually to a facility. And in the end, it turned out it was really from that drug. So it's really important to find out, like, what drug are you on? How many days ago did you do the drug? Oftentimes people may say, I haven't done a drug today, but maybe they smoked some meth 3 days prior. And so then they would be having more of a psychotic break, and they haven't slept for 4 days and they're hearing voices. And so they feel suicidal because they just kind of want to go to sleep and can't. And so at that time, one can actually offer people Ativan. They may say, would you, Seroquel, something of that nature. And then typically the person goes, well, now, I'm fine. So doing those kind of interventions, even if maybe they were running in the traffic, but they were high, does not mean that they're currently suicidal. And it was under a substance. So, but also it's more impulsive at that time. If someone's feeling really suicidal, they may actually try it because they're so miserable of the come down. And then we have purposelessness, no sense of purpose in life, no reason for living, psychic pain, reasons to live or die. So if you ask somebody, do you have a reason to live? They might say, well, my kids, or I don't have anybody, or I like my job. So you try to eke out what's important to them and why they want to live. And so you kind of, see where they're at with that. They want to have pets, that keeps people alive sometimes. So there's different things that you can kind of eke out from somebody regarding their reasons to live. I have an example here. This also includes hopelessness, just like there's no reason to go on. Also, religion. Religion actually, that's an important question to ask, because religion actually is shown to keep people alive because they don't feel that they should actually try to, they feel that's not the answer. So when we know that someone has religion, they typically have a less chance of killing themselves. And next we have anxiety, agitation, inability to sleep. So if somebody is not under the influence of anything and they're having anxiety and panic attacks, they're not smoking marijuana, which increases anxiety tenfold. The inability to sleep, then they're at actual higher risk of killing themselves. People with anxiety actually kill themselves more than depressed people because they have the energy to do it. So I'm sure you've heard kind of like about Prozac, and that Prozac can like increase your suicide attempts. It's actually the Prozac gives people more energy to then want to go kill themselves. So when they're really depressed, they don't have the energy to actually go kill themselves. And with the agitation, you'll see pacing, you'll see kind of somebody being really, really tense, kind of really hyper vigilant and alert, more so than normal. And just feeling kind of, usually people that have really bad anxiety that want to kill themselves will say, I feel like I'm jumping out of my skin. So that's like more of a severe anxiety than a normal kind of anxiety. Feeling trapped. So feeling trapped, it's like there's no way out, ineffective coping, and no way out. And so basically it's people that feel oftentimes, we had an incident with a Hispanic woman about a year ago that was told she had to move out over her place. She had, she and her husband are living in an apartment across from the school. And her reasoning was that she felt like there'd be nowhere to live and she'd be homeless with her kids. So she actually went across the street and took out her 3 children, ages 5 to 13, and killed them. And then cut her arms and went into a bathtub to try to die. So she actually lived. But again, in her mind at that time, she felt there was no way out and there was no other alternative. And she had a language barrier. There was, she felt probably isolated being in this community and not having the support system that other people have. So that's like the severity of feeling trapped. We have hopeless about the future or no future. And again, that's pretty self-explanatory. And that's what you want to ask somebody. What do you see for yourself? Do you feel completely like there's no way out? Do you feel that you have any options? Do you have anything that you can go do? Do you have something to live for, or is it just totally over? And so there's that hopelessness feeling. So when you put all these things together, you'll, if there's 1 or 2, that's okay. But when there's all of them together, that's when more of the severity comes in. And withdrawing. So we have withdrawing from friends, family, and society, social isolation, alienation, and sleeping all the time. So again, this could be a sign of being depressed, but it doesn't mean you're going to kill yourself until you have all these other factors involved. And I think, for an example, the social isolation of somebody that's actually thinking of suicide would be somebody that, quits their job, goes and drinks rum all day long, doesn't eat, doesn't shower, doesn't see anybody, doesn't go anywhere. That's more of the social isolation versus kind of the depression social isolation, when someone might isolate for several weeks at a time. And then there's the sleeping all the time. But again, these have to go together and could be just a major depression, which could be treated. And then we have anger, rage, uncontrolled anger, self-loathing, aggression, and seeking revenge. Oftentimes we see this with the seeking revenge and the aggression with more increase of family suicides when the man kills his family and then kills himself, because that's where the aggression comes in. Oftentimes women become more angry and self-loathing together with this combined with suicidal ideation. So one woman that we'd worked with had several suicide attempts prior, several 5150 admits, was, abused as a child, domestic violence. She had the whole gamut of what somebody that you would think of wanted to commit suicide or would commit suicide. So she ended up getting in her car, calling her family and said, I'm going to go run into a tree. And she had her Bible next to her and actually ran head on into a semi truck and killed herself that way. But she had a huge rage. And so again, that's something we often see. There's like kind of a dark black look oftentimes that people are so angry and almost want to attack you in a sense when they're feeling really suicidal. They can't explain it or get it out of their, verbally. So that's an example of the aggression. We have recklessness. So acting recklessly or engaging in risky activities seemingly without thinking, impulsive, reckless acting out. This does not include teenagers that like go out and sneak out and, go drink or do things their parents don't like. That doesn't mean they're suicidal. That's normal. We have impulsivity. This does not mean impulsivity when you're high. You want to look at, is this impulsivity when you're sober? Do you act out in what way? And this could be numerous DUIs. This could be numerous, just stealing a car because you want to, just doing things that are like very self-destructive, but not under the influence of drugs typically. And then there's the reckless acting out of becoming, more endangering to other people, really reckless driving, not caring, kind of, just getting in a lot of accidents all the time. So that's part of the reckless behavior example. And impulsivity also includes doing things that are dangerous as far as safety to yourself, perhaps putting yourself in harm's way. Again, not under the drug situation, because we have to say, would you have done this if you hadn't been doing drugs? That's a different situation. That's more of a drug and alcohol dependency problem. And then we have our data collection. So just looking back at what we talked about regarding this past person that killed others and himself, he had motive, he had a plan, he had anger, he had no regard for human life. He had a history of being in therapy before, he had weapons. So there were all of those factors that actually would have placed him obviously in danger to others and himself. Also, if the police had gone into his apartment, they would have found weapons as well as a chaotic scene in his apartment. So that's where the mental health piece comes in to see what's going on in that house, and so he had like posted, newspaper articles all over and these weird manifestos. And so it's like you have to be nosy as a mental health professional and look and see what that person's doing and how they're living essentially and what's going on, which would have further been able to have hospitalized that person. So that's part of that. So I'm going to give another example of an inmate we had and that he didn't have suicidal ideations and why we hospitalized him. He came from another facility. He was a white male over 45. And we had at that time we didn't have computers. And so we didn't have his information yet from the other facilities where he had prior suicide attempts. And so we looked at him and he was really pacing. He was really anxious. He'd been using meth at the other facility. It's very vague, really angry, scared. And so I put him under a 24-hour watch because he denied that he was suicidal. The person on watch and the people on watch are really important because they can, tell you what this person is doing and their observations of the person they're watching. And so unfortunately, the CNA that was watching the inmate watched him braid a rope, which you're not allowed to have in prison. And she said to him, "Why are you braiding a rope?" And he said, "I'm going to use it to work out." Unfortunately, she did not communicate that to the next person on call. So again, communication is really important when you have people on suicide watch. And the next psychologist that came in discharged him because she didn't know about the rope, and she put him in isolation, where in isolation, that's the highest rate of suicide attempts. And he made another rope and hung himself and killed himself. So again, it's that anxiety, which is really the key when you don't know, or you're wondering, should I hospitalize that person? It's the anxiety is a really huge factor. The other huge factor is abuse. With abuse being child abuse, domestic violence, sexual abuse, you have a higher rate of harming yourself. And self-harm is a huge one as well. The reason with self-harm is why it's a higher risk and danger to suicide attempts is people are used to cutting on themselves, so they're not afraid to use objects. And when, as a clinician, somebody that you might be working with as a nurse or different, they might say, "Well, I cut on myself," but you kind of don't go into it. But as a clinician, we say, "What did you use? Did you, was it a knife? Was it a serrated knife? Was it a pocket knife? Was it a glass bulb?" That's what people sometimes use. So we look at the severity of it, and then we say, where did they actually cut? And did you need stitches for that cut? So, they might be on their neck, they might be on their arms. Which way did it actually cut up their arm? Or was it sideways and tiny? Was it deep? So we look more into that severity and if somebody was actually hospitalized for that self-harm. Typically, most people that self-harm have a history of sexual abuse. And oftentimes they'll stop as teenagers, so it's not as dire, but if it's a recent self-harm, then that would be a higher risk level for suicide. And we actually had, and this is an example of people that go, "Why didn't you hospitalize that person or put them on a 5150? So we had a gentleman who was bald and was found in a shower with the water running. And he had cut little nicks all over his entire head, very small. They were not deep, but they were all over his head, bleeding, all over his entire face, all over his body. They found him in the shower. So they brought him in and said, but by the time they brought him in, he was like clothed. He was calm because he'd already, self-harm actually reduces anxiety when people cut on themselves. And so he came in, and the decision was not to put him on top of the crisis bed list, although it appeared that obviously that was a very scary situation and it looked awful. But because he was calm, sitting down, didn't have a motive at the time, said, "I'm not going to cut on myself anymore." He ate, he slept. So again, it's looking at crisis beds are not sometimes the end all to something. And oftentimes within 24 hours, somebody might be pretty calm. For example, as we talked about, if you're a meth user or trying to come off drugs, you'll be calm in like half an hour rather than having to be placed in a crisis bed. And so we look at that as well. And so then we have the history of, and I have it here. The history of attempts. And so the history of attempts is very important because, again, it's looking at the severity, and it's also looking at where did you do it? Did you get found? Did you want to get found versus somebody? Did you call somebody? So that kind of shows you it's more of a cry for help versus actually going and doing it, which typically more the white male does, and nobody knows, which is really tragic. And so typically that's what we also look at is how severe was it? Where is it somewhere that someone had found you? Another thing is a way to work with somebody that has kids that feel suicidal is explain to them that if they kill themselves, their children have a 50% chance of trying to kill themselves. And so a lot of people that are suicidal go, wow, I didn't know that. And so that keeps them from actually wanting to go through with their plan that they might have had. So we look at that as well. So there's different kind of interventions people can use for that. Again, I don't know with this referral process with the ISPATH form. Again, it's something to look at, to ask somebody for as a referral. And then again, it's kind of the spine that one can use to decide if they're going to hospitalize somebody or not. And there's a lot of different ways that people can be treated that don't need to be crisis bedded. Crisis bed is not, first of all, sometimes people that don't really need to be on crisis bed kind of take up room for other people that are really dire and an imminent trying to kill themselves. And so what we see is a lot of times, and it's better to err on the side of caution, but also people that get hospitalized and are sitting there in bed eating, potato barbecue chips and asking for their phone and asking for different things. They're not imminently suicidal. They don't need to be going to crisis bed. You're looking more for the person, let's say in the ER, that's hiding under their covers, that is not eating, that is not drinking anything, that is like more, very isolated and the withdrawal, not communicating, not talking. That's the person that really needs to be in there. And then if they'd had, a recent attempt. So you can kind of look and with the people that are on watch, they're such an important piece because they're able to tell you, oh, they talked to me for like an hour and a half and we're talkative. That's somebody that's pretty okay. And asking for, food, etc. That's great. You're eating, you're drinking, you're talking, you're not trying to hurt yourself while you're here. So those are some things that you look at to actually discharge the person. And so that's kind of the clinical approach to that. As well as, again, if you have a good treatment plan as well. With like the homeless population coming in and drug and alcohol people coming in to ERs or hospitals, the same thing. You can try to, give them different angles of alternatives. Hey, can I give, are you going to feel better if I give you Ativan? And they'll probably tell you what they want. And you'll go, okay, bye. Are you okay now? Yeah. Or somebody wants, if you just give them food and they, give them some stuff so that you can keep your crisis bed really open for somebody that's imminently suicidal. Example of imminently suicidal is somebody that's, trying to strangle themselves with the phone, with a cord, if there's a hospital cord. We've had people stuff sheets, stuff toilet paper into their mouth to choke themselves to death. We've had people that have actually, with a tiny little pencil, actually scraped out their entire veins. So those are the people that, need that imminent crisis bed versus people that there might be other alternatives for them to be placed rather than being in a crisis bed. I think people think crisis beds are, oh, it's going to be like a picnic and everyone's going to hang out and, it's sunny acres. It's not. It's very stark. It's harsh. It's more of there's nothing to do. It's just kind of caught in a room. That's it. And so you have to really think, is that really what the decision is for that, the right decision for that person? And again, it's short-term crisis is what a mental health crisis bed is for suicidal people. Also, we want to look at, of course, teenagers now have had an increase in suicide attempts and completing suicides. We have the LGBTQ group that has always been known to have a higher rate of suicide because they're more bullied and going through more, obviously, issues than another teenager due to social stigma. So they would be at higher risk, working with teens. And working with kids, what we look at if you're working with under 12, is when you see kids that are suicidal, that have drunk bleach or taken their mother's pills or done something of that nature, that would be a big flashing sign of refer to CPS, because there's a reason they're doing that. You don't meet many kids that are like, oh, this bleach looks good. That's probably they've been abused and actually been forced to drink it at certain times, we found. And also have access to pills, have access to those kind of things, which means they're neglected. So with children, it's different because you would do more of a CPS report with that. And there's a higher concern of also sexual abuse and physical abuse is 99% of why they're trying to kill themselves. And I think that's it. I have one other thing is people that are in therapy typically don't kill themselves. It's when they leave therapy. So the main answer is to try to keep somebody in therapy. And I think sometimes people say, well, they're fine. Why are you seeing them anymore? You don't need to. Well, if this person has a history of suicide and chronic, all these other factors I discussed, such as the abuse and the substance abuse and, really reckless behavior and all those together, that person has a higher chance of trying to commit suicide. So it's important to actually keep those higher risk individuals in therapy longer. Because what we see is when they're not engaged, when they're not in group therapy or they're not in individual therapy, they're all alone. They have, again, they try to kill themselves because they felt they had no support. Those are the ones that will then kill themselves within several months of not being in therapy. So that's it. Hope that helps.
Thank you, Paloma.
Thanks.
I'm just going to remind folks that if you have questions, you can ask them in the Q&A box at the bottom or in the chat box. There are just a couple that have already come in. Can you speak to the 988 crisis line? Is that something that you would recommend for someone who's in immediate crisis?
Oh, definitely. I think it's really important, again, to give your patient or friends the 988 number to call. A lot of times I've done crisis lines actually for several years, and mental health always had one. Just talking, a lot of times, sometimes it's the same person that might call often, maybe, and so you get to know the certain people that call if you're in a smaller community. And so it's just having, again, they're so isolated, they want someone to talk to, and that it just gives them that outlet. And so that you're able to talk with them and then they feel better. And, then you follow up with them or have them come in or check their medication. But it's really important to do that. And with the crisis line, they would be more apt to err on the side of, they're not clinical oftentimes, so they would probably go off more the ISPATH more model. And then refer them, or even have them send an ambulance for them, or have somebody, if there's anyone there, take them to the hospital for now an evaluation. So
Thank you. Another question is it fair to say that all suicide is linked to mental health?
I feel that, well, it's more different factors, like we talked about the combination. So one is at higher risk of being suicidal and developing mental health problems due to abuse. There's people that are born chemically with major depression or schizophrenia or bipolar that don't maybe have any of that criteria that would actually be suicidal. Those are like major parity diagnoses. So they can't, that's actually a brain disease, schizophrenia. So traditionally, yes, but there might be somebody that never had a depression before and then had it later, or, an event that might have triggered, because we often see young men and people that never showed signs of depression have an event that made them be really impulsive and created a feeling that they needed to die. So I think sometimes people go, we never saw that, because they didn't have that. So it's not always a mental health thing. It could just be a snap and a situation that might create that impulsive behavior. So.
Got it. I do see a raised hand. Let's see. I can see if maybe they're not able to ask it. So let me go ahead and see if I can get this person, George, to talk. Hold on one moment.
Okay.
And George, if you want to unmute yourself, you can go ahead and ask a question if that's what you're looking to do.
Can you hear me now?
Yes.
Okay. 2 questions. One, I noticed a lot of my friends and families under a lot more stress right now with the economy, and it seems to be spreading all the way down to the pets in the family. But the other question is, does the social media in young adults help or hurt or do anything with the number of suicide thoughts or attempts?
Right. And thank you for asking that. That could be a whole other topic. Yeah, social media has definitely increased the suicide rate. The bullying that has, shown to create kids that never had a mental health issue kill themselves. We've had foster kids that have went on Facebook and said, I'm going to hang myself, but nobody knew where they were. And so they would actually kill themselves. But, they were pleading for help. So definitely that is very detrimental. They've shown that young girls have body image issues from the social media. We've seen a way higher increase of males that actually come in that have, because of the pornography that they have access to, already have addiction problems with that, as well as not being able to have relationships with other females because of that pornography, as well as, it's typically violent often. So it really gives a distorted message. And so it is a huge problem.
Well, one of the experiences I have as a dad, now a grandpa, is a lot of times these younger folks reach out to other people who are in the same boat, who are confused. And often they seek they're asking for help from people who are, like I said, having their own issues. But this is something that we all grew up with, had our issues around 12, 13, 14. But it seems to me that they tend to find the wrong people when on the internet to get advice from. And we often don't see that. It's just something I had to throw out there.
Correct. And that's where I think, you know, being a nosy parent is a good parent, because you're going to look and see everything that your kid is posting, and also not let your kid be up at night online all the time, where who else is up that late? They're not being monitored. You know, they don't have any supervision. So and B, you don't know who you're talking to. So I think it's the parents that need to be more, you know, take your kid's phone away before they go to bed, and have them have less access, and monitor who they're speaking with.
Thank you.
Yeah, thanks.
Thank you. I don't see any other questions, but anyone else is welcome to raise their hand or ask in the Q&A box. There is an anonymous option as well. But I appreciate the question, George. I'm going to go ahead and wrap it up, but I'll keep an eye on some questions in case anything else comes through. I just want to thank everyone for spending their evening with us, the early part of the evening. And we do have a follow-up survey that we'll send out. If you have any feedback for us about how we did or future topics you'd like to hear, we'd love to hear from you. And this webinar was recorded. It will be available on our YouTube channel, and we'll post it on Facebook later tonight in case you want to refer back to it. But Paloma, we really appreciate you being here tonight and for such a thorough presentation. It's very appreciated. And I think with that, we'll go ahead and conclude about 10 minutes early. So thank you so much. I appreciate it. Thank you, everyone.
All
Thank
right,
you.
bye.